it up. Gonna be done. Lower the bed, blah, 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 right? Now it's the next day. And I'm going to do my catheter care and remove the catheter. Okay. And so the equipment that I need for that is a Chuck's pad and a 10 milliliter syringe. If I look at my Foley catheter, which I should be doing every time I do an initial assessment of my patient, I'm going to see that the catheter says that it's a 14 French catheter and it holds 5 to 10 milliliters. So in my documentation, I would say patient has a 14 French catheter that's patent, draining yellow urine. Okay, that's what my normal documentation is. So I can look at this and I can see that this is going to have a maximum of 10 milliliters of fluid in it, so I know I can come back with a 10 milliliter syringe. So when I'm going to remove a catheter, I'll need a chuck, I'll need a syringe, and a route in which to urinate. Okay, so if they can't get up and use the bathroom, I'm going to make sure I have a bedpan or a urinal. The patients, oftentimes as soon as you pull their catheter, feel like they need to urinate. Okay, so when I come back, I'm going to do peri-care. Okay, and then additionally, when I do my catheter care, the one thing that I'm going to be doing differently is cleaning the catheter. So normal peri-care, and then the last thing, I'm holding the catheter, and then I'm washing the catheter. What's this doing?
Pulling the microbes away.
Yeah, decontaminating any microbes that might be on the catheter. Okay, we do kind of do that, do a little peri-care and see what's going on before we discontinue it first, because the genital area is a moist environment. It's a mucous membrane. It's being irritated by something in it, so it's going to create mucus. The body's naturally going to be trying to expel it. So you can have the catheter, especially if people haven't been doing their catheter care, kind of adhere to the meatus. Okay, so you want to make sure that that's not happening before you pull it off. It's going to be like pulling off a scab on the meatus. It's not nice. Okay, so do your catheter care, genital care, peri-care. Clean it. Then I'm put a chuck down underneath the patient, because you will get a little dribble even if you think their bladder's empty. Okay. Take my syringe, and as I put it on that valve, it'll naturally drain out. Now you're not going to get the whole amount out, because there's going to still be a little bit that's stuck in the catheter, you know, because it's going the length of the catheter to the balloon. So if it started off with 10 mLs, it'll probably be something like 9. Okay. I do think that the longer it's been in there, it also kind of evaporates a little bit, so it's not unusual. So I always give it just like an extra little pull to make sure that there's nothing left in there. Then I tell my patient to hold their breath, not bear down, because when you ask them to bear down, you're going to get a little bit wet. Okay. So hold your breath and pull it out in one slide. There'll be a little dribble, and they might feel like they have to have the urge to pee right away. So you can give them the urinal or help them get up to the bathroom. So I want you to notice, you would think that the Foley would be all the way, empty the bladder all the way, okay? But you can notice when the balloon is full, this is sitting on the base of the bladder, okay? The holes are way up here. So you can see that I could have a little pooling of urine right here. It's not going to get everything out of the bladder, okay? That's also how come when you see the flash of urine, it's when you first enter the bladder. That's why you got to go a couple more inches so the balloon is actually in the bladder and not in the urethra. Okay, so that's what that is. So they might actually have to void, and they might actually void 30 or 60 milliliters initially right after you pull out the catheter. Then I'm going to clean up. And there you go, yes.
it doesn't affect the reflex of the sphincter up there when it stays for a long time.
There's always that potential complication, okay? And it's never, ever the same amount of time for anybody, okay? It's kind of like with that foot drop thing. So the question was for the video is if the catheter is in for a long time, does it affect the integrity of the sphincter? And the answer is it's possible, okay? It doesn't mean if the catheter is in for 3 days you're okay and 2 weeks you're not. There's nothing to measure about it. And so that's how come whenever we put in a Foley catheter, besides the risk of infection, we're also always thinking about how soon can we take it out, because it could be, and sometimes it makes the sphincter a little bit lazy. So initially, after you pull out a Foley catheter, the patient might have some urinary retention and have difficulty voiding that first time. And so you might have to be doing things like those peri washes and those other things. We're trying to get them to relax to pee that first time. It seems like once they go the first time, it seems to be better. I should say once they go the first time naturally. So if we have to cath them again because it's been 8 hours and they can't pee, then your clock starts over and you're trying to wait again and see. But once they start peeing, it seems to finally be okay.
When do you recath, how much should be the retention?
We like people to urinate within 6 to 8 hours max of either surgery or having a catheter. Okay, so
Normally, if there is a 300 milliliter or something like that, you have to get retention.
it depends on if they're having discomfort, okay, and it depends on how long it's been since they voided. And it also depends on, because we have those bladder scanners now, so we can scan their bladder. If it's been 8 hours, they haven't peed, and we do a bladder scan, and there's only like 50 or 100 milliliters in there, then we're asking ourselves, well, why aren't they making very much urine? Okay, do they need a fully a fluid bolus, so that maybe there's something else going on, and that's why they're not peeing. Okay, sometimes we don't know, the bladder scanner might not be right or something, or we can't get it to work, and then we would do a straight cath and document how much urine is in there. We also can crudé the bladder and palpate it and see, does it feel full, does it feel distended? Okay. Sometimes you do straight caths on patients to see what kind of residual void after they void they have. Okay, so are they having complete bladder emptying? So people with neurogenic bladders. Okay, so they just peed, they peed 150. If I go and cath them again, how much am I at right after their void? It's called a post-void residual. It's 150, 200 milliliters. They're not having full bladder emptying. Then we assume the void that they did have then is really because their bladder is so full, it's more of a leak than a void. Okay, and so that sets up a whole other cascades of possibilities. Okay, but you might see that.